Today, the story of Lori. You know, I was thinking the other day, I seem to know stuff that people don't seem to know anymore. And so I share with you as you can save many patients' pulps, children's and adults. Together we can truly raise the level of health in our dental patients. Think about that. Did you know you can reverse many pulpitis episodes that you might believe you couldn't and save the patient's pulps? I mean, seriously? The real point is, would you rather have a root canal treated tooth that is now brittle, vulnerable to vertical and other fractures, or a strong, viable tooth with a healthy pulp and blood vessels and nerves running through, enhancing the chance of long-term tooth health without need for repetitive dental procedures? Here's how. Oh, but first, let me give you the backstory. So I have a friend who called me recently with a cold-sensitive, lost restoration tooth. Though she knows I provide pediatric and orthodontic care, she called with a huge, for her, concern about her own dental situation after having been to her first dentist and gotten the following information. Said the doctor, "I don't think you need a root canal treatment, but there's a lost filling and some recurrent decay, and I want to do a core buildup and crown as soon as possible. We can start today." Now I'm going to mention something to you. Let me digress a moment. It's about the patient. What the doctor wants to do is not important. What the doctor recommends for the best of the patient is what's important. So I think we have to be careful with this, what I want to do for you, and use words that are more clearly in their concern. Lori's reaction was to call me, her dentist friend, and talk about it. She said, "Doc, I don't know what that means, but I wondered if it's good for my tooth to jump in and start drilling and irritating my already inflamed tooth." She went for a second opinion and was told she needed a referral to endo for a root canal first, then the core buildup and crown. Let's look at this. Let's look at the situation and what I went through with her. First, I noted her radiographs had intact PDL all around both mesial and distal roots of the lower left 6, number 19. No furcation changes. The missing restoration appeared to have been a composite, rounded shaped prep, and recurrent decay was not notable on the radiograph, as is so often the case when it's not rampant, right? That brings us now to the absolute best solution for her situation right now, as her tooth was open to dentin, cold sensitive, enough sensitivity I felt obviously inflamed pulp. And this solution I have employed many times in pediatric and adult patients over my 30 plus years of practice with total success to date. This is an absolutely priceless video for you because you can save many pulps and ultimately many teeth. So here goes. Here's the deal. Now, diagnosis. Let's review. No notable hot sensitivity. Cold sensitivity in her case, fairly impressive. Recurrent decay with no obvious pulpal proximity, though possibly could be canals in proximity, right? Not evident in radiograph. Second, some science. Science has been in short supply and usurped by BS lately. Yes, I said it. That's what it is. So let's talk about the science. Let's talk about secondary dentin. Let's talk about time. And let's talk about pulpal health. First, the science. You know secondary dentin will be laid down in a good environment within the tooth by the pulp with enough time. That good environment will include a sedative next to the pulp, which provides a bit, and only a bit, of irritation through a sedative effect. IRM. Let's talk about IRM, the history and use of it. It was developed by the military in World War II and it actually came in colors, pink and blue to denote remaining decay or no remaining decay, and white to indicate prep was ready to restore later. Studies have been very significant in findings over 70 plus years to allow formation of secondary dentin and save pulps. I'm not talking about dical, calcium hydroxide. That gives much more pulpal irritation with much poorer prognosis for an already inflamed pulp. I'm not talking about acidic glass ionomer, also much more pulpal irritation. Yes, we need to avoid occlusal trauma by keeping the tooth slightly out of occlusion. Will it super-erupt into occlusion? Possibly. And if that seems to be a problem, then a Carney-Baker splint for bedtime wear or for any wear that the patient needs is indicated. Think about an inflamed knee. Do you want to pound on it? Think about a healthy tooth. If I tap even lightly on a healthy tooth with a dental mirror handle every day for a few days, it'll inflame. Now think about an inflamed tooth. I needn't theorize on what will happen to that pulp. As to the pulpal sedation of intermediate restorative material IRM, let's now think about a simple little paper cut. Do you want to put acid on it? Or Clorox, an alkaline solution? Or put it in various hot and cold foods? Point is, it will inflame in reaction. It needs sedation, protection through temporary cover restoration, calming, a pH in proximity that will soothe at a cellular level. Third, let's now talk about what I told my friend I would recommend and do if I were her dentist. And this is what it is. This is your secret, doctor. The treatment I will explain, I call CARIES control. I learned that name years ago and have kind of stuck with it. I don't know who first said that. You could just as well call it save the pulp, save the tooth. None of the ones I have provided have ever failed in all these years to my knowledge. Sure, I haven't followed all of them, but quite a few. So what have I done to maintain a healthy pulp and leave a functioning, good tooth for hopefully life? That's the question. CARIES control is the answer. Okay, here's how it goes. Appointment 1 as soon as possible with a slow speed, large round burr. Remove all the decay at the margins of the prep area. Then remove the dentinal area decay without going into the pulp. In other words, avoid exposure, absolutely if possible, leaving even a little decay if necessary. Yet take the decay that you can safely remove. Next, fit a plain band around the tooth. Cement the band with light cure orthotype cement, cleaning off the cement in the proximal area of the prep with a Q-tip so it's not in your way for the next step. You don't need cement where it's not gluing to the tooth. Light cure, remove any excess cement. Now fill the prep area with IRM, mixed to pretty firm for ease of handling, being very careful to place it in good approximation with all dentin and enamel. It's important to prevent micro-leakage well, reducing the risk of further irritation to the tooth's vital pulp tissue. Now shape the occlusal into approximate anatomical form, though you will do so working to keep it out of actual occlusion with the opposing teeth to prevent traumatic occlusion to the already inflamed pulp. A damp Q-tip can be very helpful in this shaping with IRM. You're using firm yet not totally set IRM, which works very nicely. Now, you can reschedule the patient. I usually go for about 2 months with instructions to let you know if there are increased symptoms or any issues, and the understanding that it will be in place in situ, in situation. Let's get medically cool here, in situ, for 8 to 9 months. And you will see the patient 2 months from now, and then on their regular 6-month recall, and finally at the 8 to 9 month point to evaluate and plan final restoration, which is going to be your build-up, your core, your crown, whatever's appropriate for that tooth. The appointment in your 2-month follow-up, I would suggest a radiograph just to look at everything, and certainly appointment 3 your regular recall when due, you can take a look at symptoms, signs, and finally appointment 4, final evaluation. If all is good, you can now plan your final restoration. Lori's various visited dentists were not happy with her request for these procedures. IRM is old-fashioned. We have better methods now. Oh, what, like root canal? Like killing the pulp? I don't have bands. I don't do that. But see, doctor, this is what you can do. Lori's advocacy for her own treatment came at a cost to her and to the dentist. They were not interested in learning. Even when she offered them my phone number and the chance for information and help, they were not interested. And that's too bad, because I'm giving you gold here. And this bespeaks doom to outstanding dentistry. We must be open to learning. We must be willing to do the very best for our patients. Just as in all the toxic and dangerous drug medications that the pharmaceutical companies have been giving us, pushing over the years, our dental materials must not become limited to the newest and expensive ones that make tons of money for big pharma, big dental companies. We must use the best, whatever it may be. Our choice of materials and treatments must be based on science, solid science, and not advertised big pharma, big dentist. Our treatments must be outstanding. Nothing can stop what's coming. The collapse has begun. I'm telling you, doctor, we in medicine, in dentistry, may not even be needed in time to come, except those of us willing to learn, to work in outstanding care only, to be independent, to think, to be in canai, constant and never-ending improvement, always. And in my opinion, that is a good thing. We must not fail our mission of excellence. And as they say, you can quote me on that. You can be part of the solution. Let others be part of the problem. Thank you, doctor. Good day.